Hello, I'm Jeff Elias from the University of Virginia, and I would like to welcome you to this video course dedicated to targeting the VIM nucleus of the thalamus. The VIM may be one of the most targeted regions of the brain for stereotactic surgery, and it's been used with a variety of different techniques, including deep brain stimulation and lesioning techniques. The focus of this course, however, will be aimed toward the understanding of the targeting process and not for the different procedures used to manage tremor. Why would we target the VIM? First and most importantly, the VIM is a very powerful region of the brain to control and manage tremor. There's now a long history and experience of over 50 years targeting this region, and it's proven relatively safe with a variety of different procedures, including stimulations, infusions, and lesionings. More recently, there's a lot of work and research undergoing the connectivity of the region, which could be used to improve the targeting process and maybe even in a patient-specific manner. Historically, there were really two key issues in the 1950s that paved the way for our understanding of the ventrolateral thalamus as a region to manage and treat tremor problems. Firstly, Rolf Hassler in Germany provided seminal work and understanding of the palato-thalamic tract and a connectivity to the motor thalamus. Secondly, Cooper, who pioneered the paladotomy procedure, reviewed 300 of his cases in 1959 and found that the ventrolateral thalamic lesions were much more effective in managing tremor than the medial palatal ones. This paved the way over the next few decades for stereotactic surgery of the ventrolateral thalamus to treat tremor. There was a survey in 1985 of some of the international expert functional neurosurgeons around the world to look at the ways that they targeted this region. And as you can see from this diagram, there was a variety of different regions used to manage tremor with lesioning. But overall, many of the lesions were made at roughly 3/4 the length of the anterior posterior commissure and between 10 to 15 millimeters lateral of the midline. And this helped our understanding of the VIM region for targeting, and especially as we entered an era of deep brain stimulation shortly thereafter. The focus of the course today is really threefold. Firstly, we'll review the VIM nucleus with its anatomical and connectivity issues. Secondly, we'll talk about the different methods for targeting the region. And lastly, I'll review our technique for targeting VIM with indirect methods. The Ventralis Intermedius, or ventral intermediate nucleus of the thalamus, is named because of its location intermediately between the motor and sensory regions of the thalamus in the ventrolateral thalamic tier. This nucleus is an hourglass-shaped nucleus, as you can see in the sagittal section on the right. It's roughly 8 to 9 millimeters in height and 8 to 9 millimeters in width, as seen on the axial section. These three ventrolateral thalamic regions receive different types of afferent information and project to different efferent regions. There's the motor region, receiving basal ganglia inputs and projecting to motor regions of the cortex. The somatosensory region, depicted in blue, receives sensory information from the spinal cord and projects to primary sensory areas. And our VIM nucleus receives primarily kinesthetic information from the cerebellum and spinal cord and then projects to primary motor regions. The tremor circuit is classically recognized as the dentatorubro-thalamic tract. Localization of the VIM is based on clinical and electrophysiological observations. First on the left, just as Hassler proposed in the 1950s, there's a somatotopy of the VIM region, much like the somatosensory region posteriorly located to it, with the mouth being located medially, the hand intermediately, and the leg laterally toward the internal capsule. On the right, we can see a sagittal section where microelectrode recordings are used to map the region. Bursting neurons in the VIM can be recorded, and sometimes they're synchronously firing with the tremor and termed tremor cells. There are kinesthetic neurons recorded here that may respond to passive joint movements. Microstimulation can be used to identify the ventralis caudalis nucleus bounding the VIM posteriorly. In stereotactic surgery, we think of targeting based on indirect or direct methods. The indirect method is primarily used based on the internal landmark of the anterior and posterior commissure, or the commissural line. This line was proposed by Thalamic in 1957 and really represented an internal reference point that is relatively standard across humans. Prior to Thalamic's proposal of the ACPC line, most stereotactic procedures were based on external landmarks on the scalp and skull. Direct stereotactic targeting involves visualization of the stereotactic region or target with MR imaging. The VIM has been proposed for direct stereotactic visualization or targeting as MRI continues to improve and we're obtaining higher resolution images. Here's a 7 Tesla susceptibility weighted image which shows some of the different cellular density of the ventrolateral thalamus. And this has been proposed as a method for direct targeting of the VIM. But I think we should be cautious about direct targeting or visualization of VIM, as histological studies have shown that there are really no discrete or specific nuclear boundaries of the ventrolateral region. There certainly is differences in cellular size and density, but no specific nuclear boundaries. And that is why people have proposed connectivity as an ideal way to target the VIM. With diffusion tensor imaging, seed regions can be designated and we can identify areas that are strongly or weakly connected to these regions. And this has been used extensively to segment the thalamus and especially the ventrolateral thalamic region. And there'll be more and more investigation in this area as to the real ideal connectivity patterns that match the VIM. Others have proposed using tractography from diffusion tensor imaging to identify the dentatorubro-thalamic tract or the medial lemniscus or internal capsule that bounds the VIM. The VIM is really one of the primary stereotactic targets for indirect stereotactic planning and targeting. Because as you can see, this T1 weighted image in the center section shows that the thalamic architecture and nuclear boundaries are really not evident, thus making it amenable to a measurement in relation to the anterior and posterior commissure. I've listed our stereotactic coordinate for VIM, and I'll discuss it in more detail in the next few slides. Firstly, we'll identify on the sagittal section the anterior and posterior commissures. There's the anterior commissure and the posterior commissure at the top of the tectum in order to prescribe the rest of the imaging, reference imaging, in orthogonal planes to the ACPC line. Next, we identify the anterior and posterior commissures on a single axial slice that's been obtained from the sagittal reference. And once we've identified the anterior and posterior commissures, we draw a line, the commissural line, and measure it so that we can determine the coordinates for the VIM. Our anterior posterior dimension is 3/4 of the commissural line, seen in yellow. Our laterality is 14.5 millimeters from the midline, but we sometimes adjust this based on for different reasons. In cases of ventriculomegaly or a large third ventricle, we'll plan the laterality 10 to 11 millimeters from the large third ventricular wall. Our dorsal ventral plane, or the z-axis, is really based on the thalamic base and equates to the level of the ACPC plane for planning. Then there are other considerations that we take into account when doing a procedure based on the type of procedure we're doing and the type of clinical testing that we obtain from the patient. Sometimes minor adjustments in the VIM targeting are made based on clinical optimization or testing of the original VIM target. And there are really two scenarios where we make adjustments. One is we want to see optimal tremor rest at low clinical thresholds of testing. And secondly, we want to see transient paresthesias that are ideally located in the somatotopic region of the hand, or more precisely, the index finger, thumb, and corner of the mouth. We believe these are really ideal regions of the VIM for tremor rest. There are some technical adjustments that we'll make in the VIM targeting based on the modality that we're using. For DBS, or radiofrequency lesioning, when we're inserting a probe into the brain, we'll sometimes adjust our targeting slightly laterally as the probes tend to deviate medially with our system as the tissue is displaced. For focused ultrasound lesioning, depicted on the far right, we'll sometimes target more medially so that as we enlarge the lesion, we have the ability to make a lesion toward the internal capsule and towards the base of the thalamus. And then we always obtain postoperative imaging for quality control and to compare our stereotactic precision and process. And so I'd like to thank you for joining me for this session on targeting the VIM. The VIM has been targeted perhaps more than any other region of the brain with stereotactic surgery. It'll probably continue to be targeted and refined over the next several decades as more and more modalities are being developed to manage tremor and other disorders. Thank you.